My name is Vivian Kamphuis and I'm a PhD candidate from the Leiden University Medical Center. I will present our recent publication in the Journal of Magnetic Resonance Imaging titled In-Scan and Scan-Rescan Assessment of Left Ventricular In- and Outflow Volumes by 4D Flow MRI versus 2D planimetry. I will present highlights from the paper, so for further information please read the publication. This research was funded by the Dutch Heart Foundation and ZonNW. Accurate assessment of left ventricular in- and outflow volumes is crucial for the evaluation of cardiovascular disease and the distinction between health and disease. The most commonly used approach for assessing left ventricular dimensions and stroke volume is multislice planimetry from cine short-axis slices. However, this approach has important limitations in the presence of dynamically changing flow patterns, such as in this example of a patient with a corrected atrioventricular septal defect. In such cases, direct flow assessment at the left ventricular inlet and outlet can resolve these limitations. In contrast to two-dimensional phase contrast MRI, 4D flow MRI uses three-directional velocity encoding in a predefined volume to represent all directions and spatial regions of blood flow velocity. This technique has emerged as a suitable tool for comprehensive visualization and quantification of blood flow volumes over the cardiac valves. One way to use 4D flow MRI is to quantify transvalular blood flow volumes, which can be done by using retrospective valve tracking. This approach enables accurate quantification of transvalular flow volumes through each of the 4 valves from a single acquisition. 4D flow MRI can also be used in combination with particle tracing to evaluate the distribution of intracardiac blood flow and ventricular in- and outflow volumes. From the inflow volume, the direct flow and retained inflow portions can be distinguished, where the retained inflow is the portion of inflow that is not ejected in the subsequent systole. From the outflow volume, direct flow and delayed ejection flow can be distinguished, where the delayed ejection flow volume is the portion of outflow that was not part of the inflow from the previous diastole. Both retrospective valve tracking as well as particle tracing have shown good accuracy of left ventricular in- and outflow volume assessment with low intra- and inter-observer variation from repeated analysis. However, scan-rescan reproducibility of left ventricular in- and outflow volume assessment by valve tracking and particle tracing remains unknown. Scan-rescan reproducibility is important in the clinical workflow since patients often undergo several MRI examinations during follow-up, and also it's important to differentiate an abnormal response with prognostic importance from a normal response during a rest-stress MRI examination. Therefore, the purpose of this study was to compare left ventricular in- and outflow volumes from two-dimensional planimetry, four-dimensional flow MRI with retrospective valve tracking, and 4D flow MRI with particle tracing, and to assess the scan-rescan reproducibility of these methods. The study protocol was approved by the Medical Ethical Committee of the Leiden University Medical Center, and informed consent was obtained from all participants. 10 healthy volunteers underwent multislice cine short-axis planimetry and whole-heart 4D flow MRI at the 3 Tesla MRI scanner. Repeated scanning was done in one session after repositioning and replanning with a 10 minutes break between the scans. First, stroke volume was calculated by planimetry from multislice 2D cine short-axis images as the difference between left ventricular and diastolic volume and left ventricular and systolic volume. Then, retrospective valve tracking was performed over the mitral and aortic valve. Below is an example showing valve tracking for the aortic outflow where multiplanar reformatting measurement planes were placed perpendicular to the streamlines, visualized from 4D flow MRI at the location of peak flow velocity. Contour segmentation was performed manually on the through plane velocity encoded MPR images. Lastly, flow volumes were obtained from the area under the curve from the flow rate time curve. Using particle tracing, left ventricular in- and outflow volumes can be calculated in two ways. The first method is by performing a direct calculation using forward tracing to calculate aortic flow and backward tracing to calculate mitral flow. The second method is by using the multi-component particle tracing evaluation and then summing direct flow and delayed ejection flow components to calculate the aortic flow volume and summing direct flow and retained inflow components to calculate mitral flow. Statistical methods that were followed are summarized on this slide. In-scan and scan-rescan comparison was performed by the paired samples t-test or the Wilcoxon signed rank test. Correlation between methods or measurements was evaluated by the Bland-Altman approach. Furthermore, intra-class correlation coefficients and the coefficients of variation were determined to test agreement between scans. Subject characteristics revealed that 50% of the study group were male and the mean age was 27 years. 4D Flow MRI data acquisition was successful in all volunteers. Left ventricular outflow assessment from both retrospective valve tracking as well as particle tracing showed strong to excellent correlation with two-dimensional planimetry. The Bland-Altman plots showed small limits of agreement, however, some significant trends and bias were also seen. This table shows the scan reproducibility. For planimetry, scan-rescan analysis showed non-significant differences between scans with strong correlation and a coefficient of variation of 7%. Retrospective valve tracking for both in- and outflow showed non-significant differences between scans, good to strong correlation, and coefficients of variation of 12%. Particle tracing by forward and backward tracing only showed non-significant differences, good to strong correlation, and coefficient of variation of 9 to 11%. Lastly, when using multi-component particle tracing for in- and outflow volume assessment, correlation decreased and the coefficient of variation increased to 12 to 16%. In this study, we evaluated several methods for left ventricular in- and outflow volume assessment. From MRI, left ventricular stroke volume can be obtained by planimetry or phase contrast MRI. However, it has been shown that two-dimensional phase contrast MRI overestimates inflow volumes and underestimates regurgitant volume. 4D Flow MRI can overcome some of the shortcomings of 2D phase contrast MRI, and it has already been shown that this technique is more accurate for left ventricular in- and outflow volume assessment. Therefore, the comparison between 2D phase contrast MRI and 4D flow MRI was not repeated in the current study. We evaluated left ventricular in- and outflow by 4D flow MRI with retrospective valve tracking and by particle tracing, and compared both methods to 2D planimetry. Scan-rescan reproducibility of all of these methods was also tested. A limitation of the current study is the low number of samples and also the absence of patients' data. Further scan-rescan studies should be done to evaluate transvalvular flow assessment in patients with valve lesions, shunt flow, and decreased cardiac function. A disadvantage of 4D flow MRI with retrospective valve tracking is that it currently requires more processing time than 2D phase contrast MRI with velocity encoding in a single direction. An automatic valve tracking procedure could further improve reproducibility and reduce analysis time. In conclusion, left ventricular in- and outflow volume assessment by 2D planimetry and 4D flow MRI with retrospective valve tracking as well as particle tracing show strong to excellent in-scan consistency and good to strong scan-rescan reproducibility and correlation. This indicates that both 4D flow MRI methods are reliable methods to assess left ventricular in- and outflow volumes. This concludes the online presentation. For further reading, I refer to our publication in the Journal of Magnetic Resonance Imaging. Thank you for your interest.